Hello.
Assalamu alaikum, Dr. Sabah.
Alaikum salam. How are you,
All
Sister
right.
Noor?
Alhamdulillah, thank you for tuning in.
Sorry, we had some technical difficulties. Hopefully it's fine now.
That's okay. Are you able to share your screen or should we do that on our behalf?
I will do it actually.
All right, inshallah. So we are now live streaming on YouTube as well. So we will begin our talk. Thank you for all of those who have waited while we figure out the technical difficulties. I already did a general introduction, but for our new attendees, thank you for tuning into this new platform. This is our first event of its kind as it is virtual. The health literacy event is happy to have Drs. Wissam Sabagh, Dr. Asma Mohit, and Dr. Asma Mubin. They will be joining us to their perspectives as physicians of different specialties on the COVID-19 pandemic to provide you with as much crucial information as possible. And we will have each specialist talk for about 15 minutes, and we will have a Q&A at the end of the session, inshallah, where they will address your questions. Without further ado, I will introduce our first speaker, Dr. Wissam Sabagh. As she shares her screen, I will tell you more about her. Dr. Wissam Sabagh is currently an infectious disease consultant at Ohio Health. She is a consultant at Ohio Health, Riverside Methodist Hospital, a graduate of Damascus University School of Medicine, and she completed her internal medicine residency and infectious disease fellowship at Wright State University in Dayton, Ohio. She worked there for 11 years before moving to Columbus last year. She also wears multiple hats as she is a wife and a mother of 3 children. So I will hand over the virtual mic to Dr. Sabagh and we will tune in for your talk, inshallah.
Thank you so much, Sister Noor, and Assalamu alaikum, everyone. I'm happy to be here talking about this very hot subject. And without any further introduction or details, I mean, I'm going to start. I'll be hopefully short. I'll try to do it in like maybe 10 minutes, and then we'll have more time for questions. So I'm going to be talking about the basics. That's what I'm going to be talking about. First of all, I'm going to just explain to everybody that this virus, actually, it's a family of coronavirus. And it's not a new kind of viruses. We know these viruses for over 50 years. It's winter, but this is a new new strain. And actually it's called, again, it's the same thing that caused SARS and MERS before. And this is the one that started in December 2019 in Wuhan, China. And they decided to name the disease coronavirus disease, COVID-19. That's where the name came from. I just highlighted the letters and numbers. So that's the name of the disease. The virus itself called SARS-CoV-2, and you see why. I mean, it's just the initial of the letters. The bat is the source of this virus. And just to let you know, this is a very, it's a, subhanAllah, it's a very small particle. It's not, by itself, it cannot live. It needs like a live organ or live cell to multiplicate and just stay alive. And there is only just genome in the middle, and you see that, and a protein envelope with these spikes. And these spikes are the protein, and that's where the challenge comes when we try to create vaccine or medication. I mean, it's so complicated. So these viruses, the coronavirus family, usually, it's all started in animals and then transmitted to humans. And you can see this is like briefly. So the most recent one is this one started in bat, and we don't know how it was transmitted to humans. There are so many theories, but anyway, now it's transmitted from human to human. So transmission is really the main thing. It's an inhaled virus. It's a respiratory virus, meaning it affects the respiratory system, lungs mainly. And we acquire the disease by inhaling the droplets. When somebody has the disease, they cough or sneeze, and these small droplets contain the virus. And when we inhale the particles, actually stays in the nose and throat for a few days and then into the lung, and it causes severe problem. These droplets travel about 2 meters. That's where when we talk, it's usually, it's again, like 6 feet apart or like 2 meters. And the other way of transmission is these particles, when they fall on object, you can see, they can stay on the object for a little while. And then after that, if somebody comes and touch the area and touch nose or any mucous membrane, eyes, they can have the disease. This is just to let you know that coronavirus in general, this is not about the COVID-19. It stays on surfaces for like different duration. It could be from few hours up to few days. That's where the idea of disinfecting and decontaminating came from. Incubation, meaning the time from when you inhale like the virus until the patient has symptoms, that's usually up to 2 weeks. In most cases, within 4 to 5 days, the patient starts having symptoms. And the scary thing about this virus and what's different, you can transmit the virus even before having symptoms. So even like 1 day or 2 days before having any symptoms, you can still be infectious and transmit the virus if you have symptoms. If you carry the virus. So that's why it's really scary. In general, if somebody acquired the virus, 80% of the time they have really mild disease, like body ache, fever, very like flu-like symptoms, and it goes away. And sometimes some people, they don't have really symptoms. It can be severe in 15% of the time, and it can be really critical and require being in the hospital in the intensive care unit in about 5% of the time. The mortality rate, actually, this is different. Actually, it fluctuates between 1% in certain areas up to 7 to 10%. This is like the average, but again, it's different from one country to the other. It's higher, like in Italy, and we're seeing relatively higher mortality rate. Symptoms of the disease, the most common thing is fever. That's like 99%. But actually here in the United States, we're seeing very few cases with no fever. So just to be aware. But in general, it's flu-like symptoms: fever, body ache, fatigue, loss of appetite, shortness of breath, dry cough, and few other symptoms that's really not common, but we can see it later in the disease. We can see nausea, diarrhea. We can see loss of taste and smell. This is unique to this virus. And we can see sore throat, headache early in the disease, runny nose and sneezing like any other viral illness. So again, because 80% of the time it's a mild disease, so it can be managed at home safely most of the time. And 3 things just to keep in mind: just if somebody has the disease and staying at home, we need to make sure they have adequate isolation, and that they should be in their own room, hopefully like preferably with a window to aerate the room. And they should not share a bathroom with anybody else. They should wash hands frequently and disinfect surfaces frequently. And people who are taking care of the patient also should be careful with washing hands and disinfecting surfaces and not really sharing anything with the patient. The other thing, they should be aware to monitor themselves. If they have any worsening breathing, if the shortness of breath started to be a problem, if they start having chest pain, that again, they should seek medical attention. Supportive care for this disease, it's like any other viral illness, plenty of fluid, and it's really good, with any viral disease. And if they have fever, again, we don't really, I know fever, people are afraid of that, but it's a natural mechanism to fight infection. But again, if it's really high, if they start having chills and not feeling well, they can take acetaminophen or what's called Tylenol. They should stay away from ibuprofen or a class of medication called NSAIDs, because studies showed that this class of medication can prolong the duration of the disease and make it more complicated. They should have plenty of rest, healthy diet, and take their vitamins. And I'll mention that in general for prevention, we should now start like really healthy diet, vitamins. We should not wait until, God forbid, we have the disease. Vitamins are really good for prevention. If we have, again, if there is any red flag, if the patient has risk factor, and I will talk about those in a minute, if they start feeling really sick, sometimes they have a pulse ox at home just to monitor their oxygenation level. If that's low, they should go to the hospital or call their doctor. Risk factors, these are very important. These are like predictors who can have severe disease versus who can have really mild disease. So the more, these are the risk factors: advanced age, high blood pressure, chronic lung disease, chronic kidney disease, chronic liver problems. Obesity is a very important factor here in the United States. Actually, in fact, it's more than any other. I've seen few cases, unfortunately, with morbidly obese patient, and they died, unfortunately. Immunocompromising conditions also. So once we have the symptoms, how do we test for the disease. That's how they test. Usually it's called nasopharyngeal swab. And just keep in mind that these tests are not really 100% accurate. These are new. They don't have, again, they had emergent approval from the FDA. So we can have false positive or false negative test. Plus, I mean, when they do the test, I mean, it should be really back to the throat, and it's very uncomfortable and it can be painful. Somebody said it's like a brain biopsy. But anyway, it's just to have an accurate test is very important. And the people who's doing the test, usually they have full protection because it's really, they are at risk of aerosolizing the virus. Labs, I'm not gonna go through this, but just to be aware, I want you to let you know that it affects multiple systems, and it affects like cardiac enzymes, liver enzymes, white blood cells, and we see some abnormal imaging, especially the lung. I mean, this is one of the severe cases of pneumonia, and you see the lung should be clear. I mean, the lung tissue should be more like black, and all this white tissue is area of infiltration. So treatment, again, the most, unfortunately, as of this moment, there is no really proven treatment for COVID-19. All what we're doing is investigational. And I listed some of the things what we're trying, I mean, or what we're using. The only one that I'm gonna actually talk about is hydroxychloroquine, because it has really brought the attention of the media because the president talked about it. It's called Plaquenil, and it's an old medication. We use it for malaria, we use it for lupus. So it's not new, but it has some antiviral activity. The problem, again, it has approval to be used in the hospital, and it has some side effects. Usually if it's only for 5 days, that's for how long we use it, it's very minimal. But in general, if somebody has heart problems, we try to avoid using Plaquenil. The other ones, I'm not gonna talk about them in details. Prevention is really the key because, again, because we don't have a treatment. So the best thing to do is prevention, prevention, prevention. And there is no agent to take, like to prevent the disease. There is no vaccine yet available. They're working on that. Antibodies, that's what the body usually forms. These are like our body form after any infection, we form antibodies. We do form antibodies after COVID-19 infection. We are not sure if these have any like long-term protective effect that we're still trying to confirm that. I wanted to mention a few things. I'm sure you've heard that the BCG vaccine, the vaccine for TB, might be protective. Food and supplement, I'm sure the social media is full of things, but the ones I want to mention, vitamin C, vitamin D, and zinc. These have some like good protective effect on actually they boost the immune system. So it's really good to take your vitamins daily, I mean, as a preventive measure, and not wait until somebody has a disease and then take their vitamins. Healthy diet and healthy habits, that's always important. Prevention, again, I'm sure everybody now we're just doing the physical distancing. I don't want to call it physical, I don't want to call it social distance. It's physical distance with social connection. And hand washing is the most important thing. I mean, if you ask me about what's the most important thing, I say hand washing, because again, it's not transmitted by touching, but if you touch an infected area or contaminated area and touch your face, that's where you can get the disease. Wearing a mask in public is very important. And that's, again, even if it's not really 100% protective, actually it's protect you from spreading anything to other people and prevent you from touching your face. Other things about physical distancing, I think we all know that. I'm not going to go through detail. I want to mention a few things about social gathering. Actually, I would avoid anything, even like sleepover or friends studying together or any of that. That's really the most effective way at this point. And as far as the face mask, because again, now there is, I mean, not everybody can buy masks and it's not really available. So people are doing like handmade mask. And just one quick thing I want to mention, when you put it on and take it off, just wash your hand, try to take it off from the loops and just try to, I mean, if it's reusable, just wash it directly after that. This is what we talk about, what we hear about all the time, flattening the curve. So with all what we're doing, what we're trying to do is flattening the curve. So instead of having a surge of severe severely ill people, and our healthcare system cannot accommodate with all what we're doing. We're trying to make it like a smooth curve, and it's like a longer, but the peak is going to be lower, and hopefully we can accommodate all of them and take care of the sick people. And the last thing I want to say is stay connected while staying away, because it's causing like a huge burden on certain families and friends. And it's very important to physically stay away, but be connected with each other and check on each other. I want to thank you all. And again, at the end, I'll be happy to answer any questions. Thank you. I just wanted to have some humor at the end.
Jazakallah khair, Dr. Sabbagh. Thank you for beneficial and informative session. We will now transition over to our next speaker. Dr. Asma Mohit will address the hospital care aspect of COVID-19. As she shares her screen, I will introduce her bio. Dr. Asma Mohit is a critical care ICU doctor with special expertise in emergencies of the brain and spinal cord. She completed her training at the Cleveland Clinic and the University of California, San Francisco, followed by additional study in health delivery science. She has been in practice for over 10 years and is internationally known for her work in advocacy for neurocritical care. She is very active in the Neurocritical Care Society and is a member of its directors. So if we are going to share screen with you, Dr. Sabbagh, I will ask you to, actually, you can now go ahead and share your screen, Dr. Mohit. And I will hand over the virtual mic to you as well.
Great. Assalamu alaikum. Can you all hear me?
Yes.
Yes.
Okay, great. Here we go. All right. Bismillah, alhamdulillah, wa salatu wa salam ala rasulullah sallallahu alayhi wa sallam. Assalamu alaikum, and thank you guys for joining us in this talk. My segment, and hopefully, inshallah, I will get us back on track in terms of time and not take too long, but the goal is to talk about some very common questions that come up during hospitalization. So we will talk about some of our FAQs about severe cases that end up in the hospital, and provide kind of a general overview for people to understand what it means to be in the hospital with coronavirus or COVID-19 infection. And introduce some concepts around end-of-life decision-making and severe cases that, inshallah, then should be a nice segue into Dr. Mobinadin's talk. We will not provide specific details, specific advice about medical care in a one-size-fits-all way, because every patient is different and everybody is going to be in different situations. So it's going to depend on how patients are doing. So frequently we get asked who gets admitted to the hospital, and as Dr. Sabbagh said, about 80 to 85% of patients who get coronavirus infection will actually not need to be in the hospital. They will have relatively mild flu-like courses of illness. But of the ones that need the hospital, and of the ones that need the hospital, that 15% or so, most will not need the ICU. The patients who do need the ICU, however, can get very sick, and we're going to talk a little bit about what that means. In general, older adults over the age of 65 are most likely to be hospitalized, and specifically those that have other chronic medical conditions. But really, as you can see here, and this is what the scary part is for us as ICU doctors, is that it really can affect anyone to the point that they need to be in the hospital and potentially need to be in the ICU setting. So even young and healthy adults can be hospitalized, but overall, patients with high blood pressure, obesity, diabetes, heart disease, and chronic lung problems like emphysema or asthma, those are the ones that are most likely to get admitted to the hospital and be sicker. But again, people who are otherwise healthy may still need to go into the hospital. Generally speaking, people need to go into the hospital when their oxygen levels are very, very low, and they may need to get some extra oxygen or supplemental oxygen, as we say. This can be provided in a few different ways. The most common way that is probably the starting point is what we call nasal cannula, where you just have a nasal prong and oxygen flows up from usually a wall connection up through the tubing into the patient's nose and then goes down into the lungs. You can also be on a face mask of some sort that provides higher concentrations of oxygen. And then the most aggressive form is what we call intubation or endotracheal intubation. And what happens there is typically an anesthesiologist or ICU doctor like myself will do a procedure where they actually have to place a breathing tube down through the mouth, down into the back of the throat, into the windpipe, into the trachea, which can then provide oxygen to the lungs in a more direct way. And again, as we said, people who are otherwise healthy may still get admitted to the hospital. So in terms of who can come visit then, if you or your loved one ends up in the hospital, it's important to know that although every hospital has a different policy, in general, most hospitals are not allowing visitors to patients that are admitted. There are some exceptions. For example, if you're in the hospital for another reason, like a pregnant woman who's about to have a baby, they may be allowed to have support. And that's usually, from what I'm hearing, about one person that has to be the same person through the entire process. And patients who do not have coronavirus and are near death might be allowed to have family to be with them. But again, it's very important to check with what that individual hospital's policy is. So what's it like to be in the hospital? What kind of care do hospitalized patients get? Patients can be admitted either to a regular medical floor or the ICU, the intensive care or critical care unit. In general, patients have their vital signs checked by a nurse or a patient care technician who helps with measurements of temperature, blood pressure, heart rate, and oxygen levels. On a regular floor, this happens probably every 4 hours or so. In the ICU setting, some of these things are being checked continuously, and some of them are being checked every hour. Some blood tests may be sent every day, and some x-rays or other tests such as CT scans, as Dr. Sabaz had alluded to, those may be done as well. Now, again, this is the stage that we're talking about, is when people end up, usually when they're transitioning from being on a mask to being to requiring a breathing tube. That is when they need the ICU setting. So what does that typically look like? This is kind of a close-up view of someone putting a breathing tube in a patient. We have a little device that has a handle that goes into the mouth to open up the throat, and then we place the breathing tube in, and that's a mannequin. And then in terms of what you can see in terms of an ICU setting, this is what you would expect to see, which is a patient lying in a bed. There's a monitor up here that's providing vital signs data to the nursing staff. This is the ventilator over here. That's and this blue tubing and white tubing is going in and out, providing air moving in and out of the patient. Over here, there's IV pumps. And there may be other machines in the room as well to support organ systems, like a dialysis machine, or in some severe cases where they're doing some bypassing of the work of the heart, other machines like ECMO circuits. Again, those are very highly advanced mechanisms to support the body and the organ systems in the event that the organs are failing. Another thing that you might see in patients that end up having severe COVID, that 5 to 15% that we're talking about, is a strategy called proning. And this is just something I wanted to share because this is not something that's commonly known or talked about or shown on TV, but for these patients that have very severe lung injury, we may lay them for a period of time on their stomachs so the circulation changes in the lungs and allows some areas of the lungs that weren't getting good blood flow to get better blood flow and hopefully better oxygen levels. And worldwide, we're finding that this is helping patients recover a little bit their lung function back. In terms of other kind of general questions we get, hospitalizations can last for days, and hopefully, inshallah, if the patient is not too sick, they can then be discharged home. Or for sick patients, they can last several weeks. In sick patients, many organs, in addition to the lungs, like the heart and the kidneys, can also fail. In the ICU setting, we use a lot of medications, and we can also use some machines to take over other functions, such as breathing, helping heart function, and taking over kidney function. The important thing is to talk to the physicians, the doctors there, about the need for these treatments and whether the doctors think these treatments will stabilize the patient or help them to improve. So what kind of support then can patients receive? You know, they're not allowed to have visitors. It can be very scary being in the hospital setting. So what can they do to kind of emotionally also be supported? Again, important to acknowledge that most of patients, no matter what, if they are presumed positive for COVID or under investigation for that, they will not be allowed to have visitors for concerns of the risk of disease being transmitted to other people. Most patients also will not be allowed gifts of flowers or food of any sort, even though in a lot of our cultures, it is very common to, you know, use food to heal, often, and even from a religious perspective. But in these cases, often we are not allowed to proceed with such things. You can video chat with the patient, but the important thing to recognize is that there may or may not be resources available, such as an iPhone or an iPad, or something like that. And time, you know, it does require sometimes the staff helping. And most of all, it depends on the patient. If the patient is extremely sick, is very short of breath while they're talking, they may not want to talk, or they may not want their family members to see them that way. And that is, that's something difficult to be on the other side of, but it's something to be aware of. It's important to know that healthcare chaplains are also available to help make religious connections for the patient. Some places actually do have a Muslim chaplain on staff, and may be able to directly offer some support, such as praying with and for the patient, as well as any staff should be able to get some resources to be able to play Quranic recitations for the patient. Staff can provide updates to the family, but generally we do, in the ICU side of things, request that there be one person who's identified kind of as our spokesperson, so not everybody in the family is kind of calling multiple times a day. So we can give one person an update, and they can then act as the spokesperson to share information with the rest of the family. Now, one of the most important things that we see in patients who are very, very sick from a variety of conditions, not just COVID-19, is this conversation that we have to have that can sometimes be met with a lot of fear around what kind of decisions I need to make, or does my family need to make on my behalf. So I'm going to talk a little bit about some of these definitions, and then inshallah I'll defer to Dr. Mubina a little bit to talk about the bioethics aspect of it. So from the standpoint of a phrase you may hear called code status, that essentially is what our goals of taking care of this person are in terms of a big picture in the event that the person becomes unstable. So if someone starts getting worse, their heart is shutting down, their lungs are shutting down, how much is okay to do? Can we do CPR and shocks and put a breathing tube in? There are certain terms that are used very frequently. A full code status means all life-prolonging measures, including CPR, chest compressions, breathing support. In Ohio, typically do not resuscitate, which is where you start limiting how many interventions you're doing, falls into the category of do not resuscitate CCA, or comfort care arrest, or do not resuscitate comfort care. And the difference there is for DNR CCA, we're doing everything we can to prolong somebody's life unless their heart stops. And then if their heart stops, we're not going to do CPR, chest compressions, and breathing interventions beyond that. And the other is comfort care, where we're not going to do anything to prolong the life. And really our focus is keeping the patient comfortable, knowing that they are in the process of dying. So there's some important points here about resuscitation. Resuscitation like this may, you can have a successful effort. People can try very, very hard, but you still may not save someone's life. And then even if their life is saved, there may be some permanent damage, such as brain damage or other organs that are injured just from the period of time that the body and the brain were not getting enough blood flow and oxygen to them. With COVID, there's also a higher risk, and this is something we need to be aware of when teams go in there to do these chest compressions. What Dr. Sabah was talking about with aerosolization, there is a chance and a risk that you are increasing the likelihood of spread of the virus to those people taking care of the patient. And those folks are at risk of getting infected as well. One other decision that comes up is withdrawal of life support. And it's possible that even though the medical team does everything, the patient is a full code, they're getting all possible treatments that are available, the patient is still getting worse. And as we know, that is not in our hands some of these times, or all of the time, I should say. In these cases, stopping the artificial life prolonging treatments may be recommended in order to allow someone to die naturally. And it's important to know doctors don't want to give up. This is a very hard thing for us to suggest, and generally means that we've looked at it pretty carefully, and that we think that the chances of recovery back to where the person would want to be in terms of being able to be awake and functional and moving around are pretty low. If it is recommended to withdraw life support and agreed to, we allow death to happen naturally, generally by removing machines and medications, and then the body shuts down when it's ready to. We cannot predict how long this will be. In a sick ICU patient, in general, this may be minutes or hours. We can give medications, however, to treat pain and suffering and allow that patient to, inshallah, pass away peacefully. Now, overall survival, it's important to note that with other types of viral pneumonia, about 35% of patients on a breathing machine may still die. With coronavirus, COVID, again, this is that small percent of patients that need the hospital and are very sick. A lot more of them are likely to die compared to other viral pneumonias. We still don't know total specifics because of how fast the disease is spreading across the world. What we do know is in China, the numbers are around 60 to 80% of patients that ended up on a breathing machine ended up dying. In the UK, it was about 2 out of 3, 66% of patients on a breathing machine ended up dying. And in the US so far, we have a range of about 20 to 50%, depending on where you look at and who's published the data once people are on a breathing machine. So the best case scenario is you don't need an ICU, you're hospitalized for a few days, and then you can go home after a few days of monitoring. There are other scenarios that ICU care is needed, the patient does well, eventually goes back to a non-ICU floor, and then goes to a rehabilitation facility to get stronger or goes home. Another scenario is that ICU care is needed. A patient is very sick, and if they survive, they actually need to go to a nursing home. They can't go back home. And then, of course, there's the possibility that ICU care is needed, the patient is very sick, and the patient ends up dying in the hospital. After this, we get a lot of questions about what next steps are and what happens, for example. In those cases, the hospital will release the body based on their own set of protocols, generally to the funeral facility. And it's important to communicate on our end as Muslims that for Islamic burial, this should be expedited as much as possible. But we should also note that given this environment and the contagiousness of the disease, that our usual burial practice may have some restrictions, such as the number of gatherings for the janazah, as well as the need to bury the body in specific wrappings that are consistent with the Department of Health recommends. It's important, it's very, very important at this time with all of this going on around us that we talk to our families about what kind of treatments we would be okay with given this information. I'd also recommend, and I know this is kind of scary, but it is, for us, it is part of our faith. We should create a will as well as an advance directive or living will that can help guide families on the kind of care that you want to receive. So some things to consider. Would you be okay with a breathing tube, feeding tube, ventilator, CPR and shocks, dialysis, living in a nursing home? How much help would you be okay receiving? These are the kinds of things that doctors would ask about in a patient who's very sick when they're trying to figure out what the overall code status should be. And just in terms of wrapping up, I wanted to just show you all how we're doing right now in terms of Ohio. So these are our cases per capita by state. You can see Ohio is actually not doing too bad. Fair number of people hospitalized, but again, not doing too bad in terms of deaths per capita as of Friday. This is from the Department of Health. This is what our curve has looked like so far in terms of total number of cases. We're at over 9,000. This data was earlier today before the 2 p.m. update. And then in terms of hospitalizations and deaths, alhamdulillah, we've only had 418 deaths in Ohio so far, which is much lower than other places across the country. There is one animation that I would like to show you just to drive home a little bit about causes of death. And this is put together based on the top 15 causes of death in the United States here. And then since March 1st, where COVID-19 is, since the first case was reported. So I'm going to play this, and you can see, just keep your eye on what happens down here to the COVID-19 as we play it. And inshallah, hopefully it works. There we go. It really starts ramping up end of March. And then we can see it goes past heart disease and cancer as the highest cause of deaths per day. So with that, I would just like to end with some statements about going back to normal, since that's what's on everybody's minds right now. Inshallah, we will get there, and you know, life will be different for us, but it's going to take time. And the question that I keep asking people is, would you cut off your parachute after jumping out of a plane just because it slowed down your descent? No, you wouldn't do that, right? Because then you're not parachuting anymore, you're falling. So we aren't done with our parachute yet. Don't go out if you don't have to. As Dr. Sabal recommended, practice good hand hygiene, wash your hands. Overall, try to maintain physical distancing and stay socially and emotionally connected. And with that, I will yield the floor to Dr. Mubin. Thank you. Assalamu alaikum.
Thank you so much, Dr. Mahait, for all of that information. Just a heads up, a few people were not able to see the animation as you played it. We will make sure if that was the case for everyone, and if so, we can probably share it separately afterwards. But thank you so much for all of that information. We will now transition over to our third speaker for today. If you can begin sharing your screen, we have Dr. Asma Mobeen. She is a pediatrician and clinical bioethicist. She is a clinical assistant professor in the Division of Bioethics at The Ohio State University College of Medicine. Much of her work at OSU's Center for Bioethics involves doing clinical ethics consultation at OSU's Wexner Medical Center. She is also a pediatrician at Nationwide Children's Hospital and a fellow of the American Academy of Pediatrics. Dr. Mobeen is a board member of the Bioethics Network of Ohio and serves on the Joint Ethics Advisory Committee for Ohio Health. Thank you for joining us, Dr. Mobeen, and we will hand it over to you now.
Thank you, Nurul Huda, and Jazakallah khair, and thank you to all my esteemed colleagues. Bismillahirrahmanirrahim. Alhamdulillahi Rabbil Alameen. Wassalatu wassalamu ala Sayyidina Muhammad wa ala alihi wa sahbihi ajma'in. Begin in the name of Allah, the most merciful, the most compassionate. All praise is due to Allah, the Lord of the worlds, and peace and blessings on the Messenger of Allah and his family and companions. So I would like to begin my segment about conversations that are related to end-of-life or medical decision-making by sharing with you information about a family that I met in my work as a bioethics consultant at our hospital. And there was a young man, he was an adult, but he was a young man who had been in an accident. And he was neurologically devastated. So as a result of the accident, he was never going to be able to wake up, never going to have any awareness. Very, very serious medical situation. And we had information from his family. He had about 11 members of his family that were very involved in his care. Legally, his decision makers were his parents in the state of Ohio, both of his parents together. And so his mother and the other members of the family, they were devastated, of course, but they felt that the patient would not want to live in a situation hooked up to machines where he wouldn't be able to wake up. So that's what they told the team about their medical decision, that they wanted to withdraw the life-sustaining treatment. The father, through issues beyond his control, had been estranged from the son and the family and had not been in touch with the son for a long time, but he was still legally a decision maker. So he came to the hospital, and when he assessed the situation, he said, I'm not going to give up on my son. I'm not going to give you permission to withdraw this life support. And so there are a lot of discussions with a lot of emotion, a lot of challenge in terms of trying to get this family to come together. And in one of our ethics meetings with the entire family, there were like, 12 to 15 people in the room, a lot of emotion, a lot of anger, a lot of grief. And in our trying to help the family work through the situation, we asked them, has anyone any kind of idea about what the patient might have wanted? Like, was there any time that you had an end of life discussion with this patient? And they said, well, no, he was a young person. Nobody thinks about things like that. And so I just prodded them a little bit more. Maybe there was something you watched on TV, a movie, or something in which a situation came up, which might have triggered this type of discussion. And then the brother of the patient said, wait a minute. Do you guys remember when this person was shot? They had a family friend who had died, and not actually died, but had a gunshot wound, and then was in the hospital, and then was transferred to a nursing home on a lot of machine support. And so he had gone to visit this family friend in the hospital with his brother, who was now in the neurologically devastated state. And he told the family, he told me, he said, don't you ever let them do that to me. He said, if that ever happens to me, I don't want to live on machines, and don't let them do that to me, seeing their friend. So he related this in the meeting. And the father was quiet for a little bit. And then he said, it's not what I want, but I'm going to respect my son's wishes. It's the last thing that I can do for him, but I'm going to honor his wishes. So I'm going to agree to withdraw the life support because I know that that's what he wanted. And that was the beginning that led the family to be able to start to, if not heal, at least to begin the process of some reconciliation and some relationship building, and to move forward in terms of their time of grief. And so I want to bring that, it was not a Muslim family, but I wanted to share that with you because there was a huge difference when the family was trying to decide for themselves what they felt was appropriate, or if they had the kind of awareness of maybe what the family members' wishes were, even if it wasn't what they themselves would have wanted. Now, if I tell a story to Muslim families or Muslim people, I can hear the response right now. They would probably be like, yeah, okay, well, that was not a Muslim family, and we don't actually know what we're supposed to do. Like, we don't know what we're allowed to do. Are we allowed to have like an advance directive? Are Muslims allowed to be DNR? Because we heard that you're not. And can we have, like, what is an advance directive? And we don't even know if we're allowed to withdraw support because somebody was in the hospital. Their sheikh said told them you can never withdraw support or you're going to be killing the patient and you have the sin of murder. So you have to keep everything going because only Allah can decide that, and we as Muslims can't turn anything off. So there's a lot of things that are present in the Muslim community in terms of experience and awareness. And so I totally understand that these are the questions that we're going to be having. And in this segment, I'd like to share some of my thoughts on that, along with perspectives from some scholars and some information that may help you get started in the process of looking at these decisions. So I'm going to be talking about advance directives, about surrogate decision makers, and about withholding or withdrawing life-sustaining treatment. So as we talked about, Muslims, they don't even know if they're allowed to make these decisions. I guess sometimes these are the things that I hear. And of course, we have, kind of cultures, our cultures and our communities that we have kind of really hesitance to even bring this stuff up, or do we really talk about death, especially with somebody who's elderly? Is that okay? Is it not? People have a lot of concerns, and it's just culturally something that they have a very difficult time with. So I wanted to just share some thoughts. We're not living in usual times. We're living in extraordinary times. And living in these times we need to take certain steps to prevent more problems down the road in terms of the grief and the challenge that families may face if this goes on. So there was a couple of webinars actually that I have watched recently that I really liked in terms of some of the scholars discussing some of these end-of-life issues within an Islamic framework. So I'm going to give you those recommendations and you can look them up. They're pretty easy to find online, and you can watch them if you want more information. So one of those was one that was done on April 8th with Sheikh Yasser Qadi and with Dr. Asim Padella. And again, you can find it online. Dr. Asim's the director of the Initiative on Islam and Medicine, and also an emergency room physician. And of course, we're familiar with Sheikh Yasser Qadi as representing the Fiqh Council of North America. So what he said in this, and I actually kind of highlighted it here because I had the closed captioning on so you all can verify this or watch it. Everybody should have these conversations. he said very seriously, dear Muslims, you don't want your children or your parents or your spouse to make this decision because it's already difficult enough to see you in that state. Give them some relief, give them mercy, and make this decision for them before you get to that state. He was urging everyone, especially people who might be high risk, as we learned from the previous information from Dr. Mohit, and Dr. Wissam, what these situations could be. Have these conversations, help your family to understand what your feelings and desires are. So it's really important for us. And a few years ago, I interviewed Dr. Hatem Al-Hajj, who is a member of the Permanent Fatwa Committee of the Assembly of Muslim Jurists in America, AMJA, and which is a body of scholars of Islamic law that deal with issues pertaining to Muslim minorities in the West. And he's also a practicing physician in the United States and board certified in pediatrics. So he is one of those resources that has a really good understanding of the religious information as well as the medical information. And that's really what we need to merge in terms of a lot of these decisions. So I wrote up information about that interview and some of my thoughts in an article that was excerpted in Islamic Horizons in January and February of 2020, if you're interested in that. I'm just kind of reflecting on the disconnect that I see between what happens at the bedside and what I hear our higher level religious scholars talk about in terms of when medical treatment is obligatory in Islam. If you talk to people at the bedside, Muslims at the bedside in general hospitals, in many, many places, my experience is that people often get advice from their first line religious advisors that they have to do everything. That as Muslims, we can't disconnect everything and you have to keep everybody on everything no matter what their situation, even if they're not going to wake up. And I hear this time and time again. Sometimes we've had families calling sheikhs overseas and getting a fatwa on the phone and coming back and telling them, nope, I can't, I'll murder him if I disconnect anything, and that's where we are. So I was trying to shine some light on this, and I realized that there's a big difference between kind of what people hear at the bedside from their first line religious scholars and the information that is being given by higher level religious scholars who also have like a background in medicine or are working very closely with medical people. So as Dr. Hatem Al-Hajj explained to me, and as also Sheikh Yasser Qadi and Dr. Asim Badella in the previous webinar, you can also look at that and I'll give you some more information about other options. Really, in classical fiqh, seeking medical treatment has never been considered to be a general obligation in any of the four major schools of thought. At best, it's considered recommended by some and sometimes obligatory in certain very specific circumstances. For instance, in emergency situations or when contagious diseases threaten the health of the society and the safety in the society. So in emergency situations, many people discuss the situation that's given by the earlier scholars of if somebody's bleeding profusely from a wound and they come in and somebody could easily tie off that wound area and stop their bleeding and save their life, that person should not say, I'm going to trust in Allah and I'm not going to get treatment, because it is pretty certain that they will save their life. So in certain situations, it is obligatory, but the rest of the time, if it's not going to be curative, or the burden of the treatment is really great, those cases do not translate into an obligation to seek medical treatment. So with Dr. Al-Hajj's explanation, he was very clear, and it's written up in the article if you want to look it up later, but the only time that so more modern scholars are they're grappling a little bit more with this issue because treatments now are better than they were before. So they're a little bit more in line with ideas, some more types of treatments possibly being obligatory because the treatments are better. But they still are only obliged, a person's only obliged to take them if the disease is harmful, the medication is curative, the medication is safe, and the burden of the medical treatment is not worse than the disease itself. So if all those conditions are met, then some contemporary scholars might say, okay, in this particular case, it would be obligatory for you to take a treatment. But none of this translates into the situations that we've been talking about with the intubation, the ventilators, there's no cure that we know for COVID-19 and other issues like that. So it's rare situations, but most of the time when you're going to go into the ICU and you have to have a decision about what you want to make, or if you want to continue treatment, or even if you want to withdraw treatment that's already started, it doesn't fall under this situation. So it really is your choice. It is not mandatory. And then here, I'm going to share a little bit more from my interview with Dr. Al-Hajj. We talked about the situations in which treatment would be required, safe, curative, the risk of treatment is not close to the risk of disease. If you're getting chemotherapy for a cancer and the chemotherapy is so severe and so damaging to your body that people really wonder, do I have to go through this? The answer is no, you don't. So there's flexibility in those cases. If there's hope, if there's no hope, you don't have to intervene. If there is ambiguity about outcome, then yes, of course, we side with hope. But Dr. El-Hajj clarified that it has to be a reasonable hope based on the available scientific evidence. Now, some people may say, well, we have hope in Allah, like Allah subhanahu wa ta'ala can cure everything. I mean, he can do miracles. So why can't we have hope in Allah? Or aren't we supposed to have hope in Allah? And on the question of that, continuing treatment because Allah or God could perform a miracle, Dr. El-Hajj said, medical intervention needs to be based on the knowledge of the doctors, not on the knowledge of God. And then if Allah wants to override the decision with a miracle, he doesn't need us to help him with that. So the treatment decisions that you make really should be based on what the science is telling you. And again, if Allah wants to override that with a miracle, he seriously does not need our help with that. So with that background, I guess then we come to the question like, okay, many families might be thinking, okay, I can't make any of those decisions, so I've been avoiding the issue, so I wasn't going to think about it or talk about it. But if it's really a choice, or if I really have a choice of what I do, how do I make those decisions? Like how do I decide what I should do or not? So again, from the same webinar, I won't repeat everything that's there. You can certainly go and look it up. But some of the important points that I wanted to share, and I highlighted this in the closed captioning that you can look at as well, because it's a little terrifying, I guess, in terms of the idea that the Sheikh is saying, well, what, in your opinion, your personal opinion, is a dignified way of living? It's actually a personal preference about what you understand a dignified life to be. If the treatment is not curative and you're going to decide when do I want to continue it or when do I not. Islamic law or Sharia doesn't have a specific line, and it's a gray area in the Fiqh Council opinions. So he said the bare minimum that most scholars or ulama would say dignified living involves is being aware of your surroundings and the ability to do some type of worship or dhikr, even if it's sin. So if you have no awareness, you have no, you're not having awareness, most of the scholars would just say that that's not something that falls under the dignified living. You have no obligation to continue, and many people wouldn't even go there. But they also said that others can have a different bar, and that's acceptable. If somebody else's understanding of what is dignified living means I don't want people to clean me every 2 hours when I can't move and I'm stuck in a bed and people are wiping me up and people are trying to feed me, and I don't want to do that. That's acceptable Islamically. If you cannot cure your disease, you can choose if you feel that that is a dignified way to live. And if you think it's not, you have the haq or the right, as Sheikh Yasser said in that webinar, to make a different decision and to refuse treatment if it's not going to be falling in the obligatory treatment section. That's kind of news to a lot of people, I think, for the Muslim community. And Dr. Asim also was clarifying in that section potential guideposts for decision making that he has written on the concept of taklif, like if someone is mukallaf and is accountable before Allah, if they can do things, they can pray, they can whatever and meet that accountability. But if they get to the point where they can't and they're never going to regain it, maybe that's a guidepost for making those decisions. And the concept of karama, and the dignity that Allah subhanahu wa ta'ala has created humanity with. وَلَقَدْ كَرَمْنَا بَنِي آدَمَ from the Quran, right? How do we continue living in a dignified way, and what do we think of as not dignified? And we have the ability to make those decisions. For some people, they may say, just if I'm lying there and I can't move and you can put an iPad in front of me and press play and I can follow the Quran with my eyes and I can listen and I can make dua for you and my family and the grandchildren, I'm good. That's all I want to do. Other people may say, no, if I can't get up and I don't want to be bedridden, and if I have to have people cleaning me up all the time and this and that, I don't want to exist. I don't want to continue. And those are legitimate options according to Islamic law, according to the scholars. So with that, I want to talk a little bit about advanced directives and just give you a little bit of information to help you get started on some of these conversations and thoughts. So advanced directives, and it's advance without a D, so that's something that you make in advance, a directive that you give before. They're legal documents that explain how you want medical decisions to be made if you're not available to make them yourself. They include things like living wills, which describe what type of medical treatment a person would or wouldn't want. Now, these are kind of hard to use clinically because you may say something, but the whole clinical situation is not apparent. And so it's very hard sometimes to apply or to understand what somebody meant in the living will. Another advanced directive is the healthcare power of attorney paperwork, which is the choice of a decision maker for you. It empowers another person to make medical decisions on your behalf when you can't do it. And this is also called a durable power of attorney for healthcare or healthcare proxy. And if you have a choice, or if you just want to get started, I would say do the healthcare power of attorney first. Choose your decision maker and then have a conversation with your family about what you want and with your, with your decision maker. These are the forms. They're pretty straightforward. I'm going to give, and the main part of the form is basically just naming the agent. Okay, so I'm going to give you a website that has comprehensive instructions, but locally here in Ohio, you can just Google Franklin County healthcare power of attorney forms, state of Ohio, things like that, and you will come up with these documents. And you can name a decision maker, and then you can name an alternate. And this actually has a 50-page pamphlet that goes with it. It's got a lot of extra stuff in there and some information and stuff, but I wanted you to have access to comprehensive information if you wanted it. But really, if you can decide on a decision maker, go with that, and then have the conversation with your family to educate about your wishes. And I would say not just the person who's your surrogate, but also the extended family. Just because, look, in the case that happened that I talked about in the beginning, you may tell one person, okay, I don't want to be kept alive on machines if I'm not aware, if I can't get out of bed or whatever. But other people who are not here, who haven't heard that, may still feel like it's not okay, or that wasn't really what you wanted, or we're Muslims and we don't do that. So for you to help share with them would also be relieving of distress in the case, which hopefully we hope it doesn't happen, but in case it happens. In terms of surrogate decision makers, if you can understand yourself, the illnesses, the risks, the burdens of the treatment, and make a decision consistent with your values, and you are able to communicate this information, you are your own decision maker. People are not going to ask anybody else. If your family comes to the team and says, talk to us, they are bound by law and by hospital policy to speak with the patient first. And now that, as Dr. Mohit had mentioned, we are not even allowed visitors and stuff. So people will start with the patient. But if the patient cannot make those decisions, then they will call on the surrogate to make the decisions. And it's really important for the surrogate to make decisions based on what the patient would have wanted. The standard is if you could wake up the patient themselves and ask them, that's what you're trying to convey to the team, the patient's values, not what you would want on behalf of the patient. And in Ohio, if you have not named a surrogate decision maker, especially for withholding or withdrawing life-sustaining treatment, there is a legal list that people go through. And this is generally the list that people use for medical decision makers as well, although there's a little bit more flexibility in that in Ohio law. So the first person, if you don't have any paperwork and you end up in the hospital and you don't have decision-making capacity, your spouse would be the person that they look to. Now, just one note, if you have had a nikah, but you have not had the civil paperwork done in Ohio, and you got married in Ohio, then that's actually not considered a legal marriage, and that might cause a problem in terms of your being a decision maker. If you had a nikah someplace else and come into Ohio and it was valid in whatever country you had it in, then that counts. But if you come here and you don't actually do it during the time you do the legal paperwork, there may be an issue. Now, we don't actually ask for proof of marriage. A lot of times when we just ask who's the spouse, but sometimes it's just the question may come up if you have different last names or something. So there is that issue. Ohio doesn't accept common law marriages and hasn't since 1991. So if people were married before then, there may also be some criteria that you could make where people would accept it. But there's a small chance there might be a problem. So if you have that situation, you might want to really be careful about filling out the power of attorney paperwork to make sure that you have who you want, especially if it's your spouse, to be the decision maker. If the spouse is not available or there's no spouse, adult children are the next Ohio in line for the Ohio decision makers. And it's the majority opinion of your adult children, which means anybody 18 or over. So if you have an 18-year-old child, that person is your decision maker, actually over your parents and over the aunts and uncles or siblings of like a person. So that's not intuitive maybe for many of us. So again, this is why I'm telling you that if you don't like this list or this doesn't work for your family, then you might really want to be careful about picking, because we've had situations, Muslim families, there's like an 18-year-old child who's making decisions about withdrawing, or supposed to, the team is going to them, and he's on the phone with somebody in some other country, an uncle of the patient, trying to understand, what do I do? And that uncle's asking some sheikh someplace else, and the sheikh is telling them, no, you'll kill her if you remove anything and you can't do anything, and that person is not there. Really been hard. It's very stressful on families. So have the conversations and pick your decision makers. If you make those documents, they have a higher priority than the list. And then higher than that would be like a court-appointed guardian or somebody that people might have. And then just one quick note about withholding and withdrawing life-sustaining treatment. As we talked about, the criteria that talk about if something is obligatory also applies to withholding and withdrawing life-sustaining treatment. Muslims can do both if the treatment is not curative and meets all the criteria, the burden is not great. We can do all of that. It's okay. But it feels different. I mean, it does feel different to say I'm not going to start a treatment versus to do something that in your mind, it feels like you're flipping a switch and that person's stuff is being turned off and then they die shortly after. That feels very different for families and for medical teams. So no doubt, I mean, it's not that it's wrong according to the discussion that we had, but it can make a big difference. So for this, sometimes scholars will say you should just withhold, like you shouldn't withdraw. Once you start something, you shouldn't turn it off. And I don't think that's backed up by the discussion that we had earlier. So I don't think that's true Islamically, but sometimes families feel that. So scholars have clarified, and you can look at those webinars that I talked about, it's not murder from an Islamic standpoint to withdraw a ventilator. And if you withhold because you don't want to have the situation where you might have to withdraw a ventilator, just be aware that if you're withholding due to that fear, that doesn't allow a timed trial that could restore a patient to better health. So if you have a 30% chance of doing okay and getting off the ventilator and being better, that's, 1 out of 3 is not bad odds. And so if you don't try it, you won't know. But if you try it and then it's not working, then after a certain amount of time, you do have the option, Islamically even, of withdrawing. So sometimes it is better to do the trial. Other times, not. In terms of your goals of care, it's better to define goals in terms of what your goals are, as opposed to maybe what you specifically don't want. So better for you to tell the team and your family, I want to continue if I'm able to make dua and mentally say my prayers. If I can do that, try to get me to that goal. And if you can get me there, then keep going. But if I'm not going to get there, then I don't want treatment. Or you could say, I don't want to be bedridden. If you can't get me to a state where I'm not going to be bedridden, then I don't want treatment. But in terms of what you want to be able to do or so, it's better than I don't want to be intubated. Because intubation and the medical support are tools. So the hospital, the team can use those tools to try to get you to the state where you want to be or don't want to be. But just to say, I don't want to be intubated, that's not really clear. You could have something short-term that could easily be treated and you could be fine, or you could be long-term on it. So it doesn't really clarify what you want. Now, if you have a terminal illness and you've been intubated before and it was the worst experience of your life and you don't want to do it again, that's a different situation. And in that case, you might put in your treatment goals or something, I don't want to be intubated for specific reasons. And as we mentioned, please tell your family and even extended family if you can, to kind of save them some of that grief. Here's another webinar that I thought was really good if you're interested in more information. I'm sorry, I feel like I've gone a little bit over time, but I'm going to end with a small reflection. Do you remember when we used to be able to go to the masjid? And this is our dear Masjid Noor. When we used to go, we used to pray at the masjid. And we would often hear from the imam before we prayed, as you do wherever you are listening to this, I'm sure. Pray as if it's your last prayer. The reminder, pray as if it's your last prayer. How often do we hear that? And why do they say that? Because sometimes without the reminder and sometimes with it, frankly, you often are, you're distracted in your prayer. You think about the groceries, or I got to pick up my kid from school, or I have a work project I got to finish, and it's hard to maintain focus. But if you knew that this was going to be your last prayer, how would you pray? With what intensity of focus would you be able to kind of approach that prayer? Now, suppose you were given the vision, the information, the knowledge that when you left this masjid, right on that corner as you drive out, a truck was going to hit you and you were going to die. This was going to be your last prayer. How would we pray in that moment? I mean, how would we pray? With what depth of sincerity and connection and focus would we make that last prayer? For forgiveness, for care for our family, for where we're going to go after, for those moments where what we still say and do has an effect on our eternity and our relationship with Allah subhanahu wa ta'ala, our Creator. How would we pray in those moments? And then what would you do after the prayer? Would you call somebody? Would you call a family member and say, I'm sorry? Or would you call somebody else and say, I forgive you? I really do. I really forgive you, to try to prevent your family from carrying the grief that they might be carrying with your relationship forever, basically. There's a lot of things that we might really do differently if we knew it was our last prayer. And so with that reflection, I wanted to remind us, sometimes people will come to the hospital, and sometimes non-Muslim families, but sometimes Muslim families, and more often Muslim families, and they'll say, don't tell him his diagnosis, or don't say the C word, cancer. Don't say the H word, hospice. Don't tell him. And I've heard people saying, don't tell him if he's positive, if he's got COVID-19. Because why? I know it's from a good intention. They want somebody not to be upset or maybe to keep giving them hope or something like that. But really, if you look at it, you're trying to keep that person in a state of ghafla. You're trying to still keep them in that state of heedlessness or obliviousness to what's really going on. If you look at this example or this reflection, would you really want to just think, I wish I had thought of the groceries, or I wish I had still been deciding how, am I going to go pick my kid up after school and how do I manage the groceries with that? Or would you really want that opportunity to share those last moments and maybe what would be the most sincere prayer you have in your entire life with Allah? I would say, let's think about this. Let's not deny ourselves this, and let's not deny our family members this experience. And what we can do to help with that is have the conversations. If you know everybody's okay with it, you've talked about it, you're prepared, it will be easier in those moments, and we can make better use of that time. We're living in extraordinary times. But in extraordinary times, you have extraordinary opportunities. May Allah subhanahu wa ta'ala grant us the ability to rise to the occasion. Jazakallah.
Thank you so much, Dr. Mubinuddin. That was some excellent content and reflection. Thank you so much for that. To wrap up, we have received a lot of questions and our speakers did their best to answer all of them on the Q&A. However, we will give each speaker 1 to 2 minutes to address one question that may be beneficial to the rest of our audience. Due to the time restraint, we have only one question for each speaker will be answered publicly online. We will begin with Dr. Sabbagh. We had some questions on plasma donation. Would you like to provide an answer on that, inshallah?
Sure, it's a new work. It's not a new, we know that basically what we do, we take plasma from people who had the disease and recover, and we transfuse it to sick people to give them the antibodies that usually the body. It's relatively safe. It's similar to blood transfusion. It's not haram. I had this question. There is no, again, it's similar to blood transfusion. We need donors. That's really the main problems. And the Red Cross here in the United States is contacting people. And if you have somebody who had the COVID-19 and recovered, and they're already 14 days after no symptoms, they are eligible to donate plasma. One person, if they donate, they can help 4 people who are deadly sick from this disease. The result, again, we have conflicting data so far. It's helpful. Today, this morning, I just had a report from, that it's not really promising, but again, so far we're doing it. It's not widely available. Certain centers are doing it. And again, donation is really very, encouraged by people if they can donate plasma. And again, it's, the only thing, they should be symptom-free for 2 weeks at least, and they had confirmed disease. The other question, I'm going to mention it very quickly, reinfection. Yes, it can happen. We don't know if it's really a new infection or it's reactivation of the old infection that we're still trying to figure out.
For sharing those answers. Next, Dr. Mahid had some questions that she addressed, and I know you want to address the chaplaincy question that we received earlier.
Sure. Assalamu alaikum. So, Jazakallah khair for this opportunity, and I have a visitor, so please just bear with me for a couple of minutes. We just talking a little bit about support, two aspects real quick. One is, yes, we had, as we discussed in the talk, for pregnant women, there's generally a support person allowed. Just check with your local hospital to know what the exact rules are. And in the broader scope of support, chaplains are healthcare workers that can help provide support to patients and their families in the time that a patient is hospitalized. Some places we are fortunate to have Muslim chaplains, and they have a deeper understanding, obviously, of our faith tradition. But there are healthcare chaplains who have studied a variety of faith traditions and can still help connect people with the resources either within their community or specific resources such as the ability to listen to recitations of the Quran while they're hospitalized. So that is a very under-recognized, underappreciated resource that does exist in the hospital setting.
Jazakallah khair. And thank you so much, Dr. Mubinuddin. You really nailed all the points in your presentation and provided us with a valuable reflection. So thank you for that. Once again, to wrap up, we will have this recorded and saved on the NICC YouTube, inshallah. It's under Noor Ohio. So you will be able to find it there. We will try our best to share the questions that we received as well as the answers that our speakers provided. The downside of having a virtual meeting is really that you don't get the round of applause that we usually have for the end for you. But thank you so much for taking some time to share your expertise and being on the front line and making those sacrifices for the rest of us. Jazakumullah khair for all of that. And inshallah, this is one of many talks we will provide while in quarantine. If anyone has questions from our attendees, you can email those to us on education@noodohio.org, and we will be sharing this content soon with you, inshallah. So jazakumullah khair and an early Ramadan Mubarak to everyone.
Thank you.
Thank you.
Thank you. Assalamu alaikum.
Ramadan Barak.